Welcome to Critical Matters, a sound podcast covering a broad range of topics related to the practice of intensive care medicine. Sound provides comprehensive critical care programs to hospitals across the country. To learn more about our programs and career opportunities, visit www.soundphysicians.com. And now, your host, Dr. Sergio Zanotti.
Welcome to the last episode of Critical Matters for 2024. For today's episode, we will deviate from our usual pattern of discussing a clinical topic with an expert guest, and instead I'll go solo, and I will do a year-end review for 2024. I will comment on a couple of guidelines that I found relevant and would want to make sure every one of our listeners takes a look at, and then I'll dive into 5 clinical trials that I've chosen either because they were highly cited, have an impact on our practice, or just were particular interest to myself. And finally, we'll close with the customary non-clinical questions, and I'll share with you some of the favorite books I read and this year and why. So first, before we start, I would like to thank all of you for listening to Critical Matters throughout 2024. I hope that we can continue this journey together in 2025 and can discuss a wide variety of clinical and non-clinical topics that are relevant to the practice of critical care medicine at the bedside. So without further ado, we'll go ahead and get started. I'm always a big believer that clinical guidelines are important documents to read because they summarize the existing literature, try to incorporate newer studies into our practice, and I think provide a nice overview and a source to dive deeper into specific topics. There was a plethora of excellent clinical guidelines published throughout 2024. Obviously, we're not going to go into all of them. Some of them were discussed in more detail on the podcast. But I do want to point out 2 important guidelines that I believe everybody should be paying attention to from the last 12 months. One was published earlier in the year, and one just literally was released a couple weeks ago in December. Both of them relate to the care of post-cardiac arrest patients in the ICU, a topic that for the last decade has really been, I think, fixated on therapeutic hypothermia, yet we do know today with the science that there's perhaps a lot of other things that we should also be paying attention to. So I want to make sure that I bring these up to your attention. The first one is the critical care management of patients after cardiac arrest, a scientific statement from the American Heart Association and Neurocritical Care Society. And really in this wonderful document, the authors discussed in detail the physiology and clinical care of the post-cardiac arrest patient in the ICU, and really focus on the interaction between the brain, the cardiovascular system, and the lungs. There is an enormous amount of data, information, studies reviewed, and really points out to how much we still have to learn, but also how much can be done for these patients in terms of optimizing their post-cardiac arrest critical care, with focusing on brain oxygenation, perfusion, making sure we understand what the ICPs are, understanding cerebral autoregulation, very, very prolonged conversation, something that we discussed in more detail here on the podcast in terms of the neurological support for these patients with seizure management, understanding abnormal EEGs that are not related to seizures, providing better terminology for myoclonus. I think anybody sees abnormal movements and they think this patient has myoclonus, but really understanding that there is a plethora or different types of myoclonus and where they have EEG correlates or not makes a significant impact on their prognostic importance. They also talk about the 2C, which is a spectrum of abnormal periodic or rhythmic EEG patterns that do not meet the criteria for seizure or status epilepticus, and trying to understand that a little bit more for the non-neurologist or the epileptologists, which I think is the majority of our audience. They provide the most current available evidence for cardiac management in the ICU, talking about target MAPs, timing to the cardiac cath, and the role of cardiac mechanical support. And finally, they also talk about how to organize post-cardiac arrest care and where can we have some protocols, how do we designate special places. So I think a lot of very valuable information, and I will add the link on the show notes, but highly encourage people to look at this guideline. There's a lot of very actionable clinical information, and one of the things that I found also a nice refresher was they provide a nice review of the appropriate neuroexam for a comatose patient. I think that as intensivists, we rely obviously on a lot of monitors and devices, but a good exam, especially for the neuro aspect of our patients, is always, I think, important and a good reminder. The second guideline that I wanted to bring to your attention in our year-end review is one that came out in the month of December. It's the ILCOR summary statement. So it's a 2024 International Consensus on Cardiopulmonary Resuscitation and Emergency Cardiovascular Care Science with treatment recommendations. It's summary from the basic life support, advanced life support, pediatric life support, neonatal life support, education implementation, and teams and first aid task forces. So really this is an update to the 2020 ILCOR cardiac arrest guidelines. They recognize that there are certain areas and certain PICO questions that have had new studies and wanted to reevaluate recommendations in these areas. So this is a very lengthy guideline. It's over 100 pages, and this is just a summary. They talk about basic life support, advanced life support, pediatric life support, neonatal life support, education, implementation, and teams and first aid. And my focus for this audience, obviously, is advanced life support. And I think that there are certain things that are very relevant. They review all the recent studies on post-cardiac arrest, oxygenation, and ventilation. I think that ultimately what they recommend is that post-cardiac arrest, we continue with 100% oxygen until oxygenation can be reliably measured, either by arterial sticks or a reliable pulse oximeter. And when we have that reliable measurement of oxygen, that we should target saturations between 94 and 98% and the arterial oxygen between 75 and 100 millimeters of mercury. They also review the existing studies on ventilation and ultimately recommend that we target normal capnia, so a PaCO2 of 35 to 45 millimeters of mercury. They do talk about post-cardiac arrest temperature control. As I mentioned earlier, I think this has by far consumed all the air in the room when we talk about post-cardiac arrest, and people have equated post-cardiac arrest care in the ICU with therapeutic hypothermia or with a targeted temperature management. However, the last several large randomized studies, some of which we've discussed in detail on Critical Matters, have really not shown the beneficial effects that some people expect or believe in from temperature management post-cardiac arrest. And again, they review the existing literature and make comments. This is still, I think, an area where some people are having a hard time letting go of what I think is confirmation bias. As somebody who endorsed and believed in cardiac arrest today, I really believe in hypothermia post-cardiac arrest, I truly believe that today the available evidence does not suggest that this is beneficial for our patients, and we should probably be focusing on all the other things I mentioned in the previous guidelines. But in any event, they update the terminology. So the term targeted temperature management has been updated to 4 different terms. Number 1, hypothermic temperature control, which is active temperature control with target temperature below the normal range. Number 2, normothermic temperature control, which is active temperature control with the target temperature in the normal range. Number 3, fever prevention temperature control, which is monitoring temperature and actively preventing or treating temperature above the normal range. And finally, no temperature control, which is no protocolized active temperature control strategy. And the question really is do these active temperature control therapies or protocols actually help our patients post cardiac arrest? So they review a series of PICO questions, talk about hypothermia 32 to 34 degrees Celsius compared with normothermia, or fever prevention 33 Celsius compared with 36 Celsius, duration of cooling 12 to 24 hours compared with 36 hours of temperature control, or 48 compared with 24 hours. They also look at the method of temperature control, look at the rewarming rate, and the duration of fever prevention after initial temperature control. So really review a large amount of available literature. Some of these studies obviously are smaller studies, but there are some very important studies in the temperature control area with RCTs that ultimately enroll over 3,000 patients when pulled together. And I think that this is something that we should be paying attention to. Ultimately, their recommendations and good practices statements include suggesting actively preventing fever by targeting a temperature of 37.5 or less degrees Celsius for patients who remain comatose after return of spontaneous circulation from cardiac arrest. So this was obviously a weak recommendation with low certainty evidence, but I do believe that is where we should be focusing our protocols on. That is where the evidence currently is pointing to. And they do obviously raise the question of whether subpopulations of cardiac arrest patients may benefit from targeting hypothermia at 32 to 34 degrees Celsius remains uncertain. So I would say that for now we stay away from that unless it's within the context of clinical research. Comatose patients with mild hypothermia after ROSC should not be actively warmed to achieve normothermia. That's a good practice statement. They recommend against the routine use of pre-hospital cooling with rapid infusion of large volumes of cold intravenous fluid immediately after ROSC. That has been demonstrated to be harmful. So that's a strong recommendation. They also suggest surface or endovascular temperature control techniques when temperature control is used in comatose patients, so really no difference. And when a cooling device is used, we suggest using a temperature control device that includes a feedback system based on continuous temperature monitoring to maintain the target temperature. That's a good practice statement. So as you can see, the enthusiasm for therapeutic hypothermia and for targeted temperature management that includes subnormal temperatures for post-cardiac arrest patients is slowly, I think, dissipating, despite some people still advocating for it in certain subgroups based on small studies. I do believe that trying to be as impartial as possible, the current evidence would suggest that we should be keeping temperatures below or equal to 37.5, and that should be our focus on these patients. In terms of the other suggestion in terms of length that we should focus, the 2024 good practice statement on duration of fever prevention, they suggest active prevention of fever for 36 to 72 hours in post-cardiac arrest patients who remain comatose. This is a good practice statement. So I think that for the first 36 to 72 hours, that is what we should be focusing on. They also talk about post-cardiac arrest seizure management, and I think that one of the most important things here is that it is not suggested that prophylactic anti-seizure medication be utilized in post-cardiac arrest adult patients. They obviously suggest treatment of clinically apparent and electrocardiographic EEG on EEG seizures in post-cardiac arrest adults. That's a good practice statement. And there is still a lot of discussion on what to do with other rhythms, but they do suggest treatment of rhythmic and periodic EEG patterns that are on the ictal-interictal continuum, that's the 2C, in comatose post-cardiac arrest adults. They also provide standardized critical care EEG terminology. I'm not going to go into detail here, but I think it's important to understand that obviously clinical plus EEG correlates is what ultimately determines, electroclinical seizures, and that is really what we should be focusing on. they review the available literature, which is not very large, in the use of ECPR, extracorporeal cardiopulmonary resuscitation. All they can really say is that for some patients, it might be indicated, more to be studied. So these two guidelines, I think, illustrate the complex world of caring for post-cardiac arrest patients. These patients obviously are frequent in our ICUs. As a group, have a very poor prognosis, but we do want to make sure that we are focusing on evidence-based strategies that will provide this very sick population the best chance for a meaningful neurological recovery. There are many other aspects of post-cardiac arrest, like neuroprognostication, that we didn't discuss and were not discussed extensively in these guidelines. But I do believe that it is time for us to look at the bigger picture, and instead of obsessing over what temperature we should be using and protocols and arguing about this and that, look at the whole body of evidence, look at these current guidelines, and just for now, until we have better studies, focus on keeping patients at 37.5 or below, and that we really create protocols and improve care in all the other aspects that are mentioned in these two guidelines. So I think that is what I chose to review for the NDA review. Like I mentioned, there are many, many other guidelines of great interest, of great value. We can't cover everything, but I do think that these two in particular together, one that came early in the year and one that comes at the end of the year, is something good for people to look at as they prepare for 2025. Okay, now we're going to move on to some clinical trials. Again, there were multiple clinical trials. I'm sure that there's some that I could have mentioned that I don't mention, but I had to pick and choose. So I chose based on a couple of criteria. One was a number of citations. The other one was whether it has a direct impact on what we do on a daily basis. And number three, for some articles, just articles that for whatever reason I found interesting. These are all articles that were very well conducted. I'm not going to spend time going into depth on what could have been done differently, what are the limitations of a study. I think those are well discussed in editorials, well discussed in the articles themselves. But I do encourage you to pick up these articles and look at them yourself. I think that running clinical trials is extremely hard, and I'm always more interested in just what can I learn from what's published, recognizing that there is a tremendous bias in science, and a positive trial is more likely to be published. But we should really understand a little bit more about what a p-value means. It doesn't mean that it's real, doesn't mean that it's clinically significant, but it just means that it's more likely to be published. It could have been totally random, right? 1 out of 20, it might be give you a positive p-value and still be a false positive. So again, I think that just with that, a grain of salt, I'm going to share some studies that quote unquote are considered positive, but I also think that they touch on topics that are relevant to our daily practice. So the first one, and these go in no particular order. They might be sort of in a chronological order, but not necessarily. The first one was published in the New England Journal of Medicine, non-invasive ventilation for pre-oxygenation during emergency intubation, the pre-oxy trial. This was a multi-center, randomized, pragmatic, obviously unblinded parallel trial, 24 sites, 7 EDs, and 17 ICUs in the U.S. It enrolled a little bit over 1,300 adults requiring emergent intubation, either in the ED or the ICU. And they were randomized to get pre-oxygenation before their intubation with non-invasive ventilation or with oxygen, with a regular oxygen mask at 100%. The primary outcome of this study was hypoxemia during intubation. So SaO2 below 85% after induction to 2 minutes after intubation. That was the primary outcome. Secondary outcomes were the lowest oxygen saturation. They had some exploratory outcomes such as hypotension, need for vasopressors, the presence of cardiac arrest, and then they looked at some safety outcomes, in particular aspiration, new infiltrate on the X-ray at 24 hours, and hypoxemia at 24 hours. So I think that we intubate on a regular basis. optimizing every step of intubation is very important. We discussed previously airway management and the use of video laryngoscopy, and there's been trials on that area last year. But this one, I think, focuses specifically on the pre-oxygenation, where we use non-invasive ventilation via CPAP or BiPAP machine versus just the usual air mask with oxygen and bagging. In terms of the intubation procedure, 95.5 of the non-invasive ventilation patients received non-invasive ventilation as pre-oxygenation, and 98.8 of the oxygen mask received oxygen mask. There was a little bit of crossover. In terms of other important things, the duration of pre-oxygenation greater than 3 minutes was in 96.6% of the non-invasive and 95% of the oxygen. And then in terms of the primary and secondary outcomes themselves, the primary outcome of hypoxemia during intubation occurred in 9.1% of the non-invasive ventilation versus 18.5% of the oxygen mask. So that was considered a positive from a statistical standpoint, and the 95% confidence interval was either from, the average was minus 9.4% in terms of the odds ratio, but it went from minus 13.2 to minus 5.6. So clearly very, very significant in terms that it is less likely to be hypoxemic when you emergently intubate somebody and pre-oxygenate them with non-invasive ventilation. In terms of the median lowest oxygen saturation, it was 99 versus 97. So that's from 95 to 100 in non-invasive and from 89 to 100 in the oxygen mask. And then they look at some of the other important ones. The presence of cardiac arrest was small in both, but 0.2% in non-invasive and 1.1% in the oxygen mask. In terms of success for first intubation, 82% versus 81%, no significant difference. And the median time from induction to intubation was about the same, 115 versus 113 seconds. When you look at some of the safety outcomes, and one of the things that people obviously are concerned about is aspiration. There was no difference in new infiltrates. Operator-reported aspiration actually was lower, but not significant in the non-invasive, or the presence of new pneumothoraces. Some of the exploratory clinical outcomes, there was no significant difference between the median ventilator-free days, the median ICU-free days, or the in-hospital death. So from a primary outcome, this was a positive trial. I think that there was 9% versus 18.5% incidence of hypoxemia. The incidence of aspiration was lower with a non-invasive, 0.9% versus 1.4%. And I think it just illustrates that it might be a better way of oxygenating patients. I think a lot of people during COVID had that experience when we had patients frequently on non-invasive, and then when they had to be intubated, obviously intubating them from non-invasive directly to the intubation. But I think that this is an interesting study that suggests that perhaps we need to change a little bit what we do routinely and be a little bit more thoughtful about how we organize every step of an emergent intubation. And this is obviously focusing on the pre-intubation or pre-intubation oxygenation. They also did a subgroup analysis, and you can see that in general, it favors non-invasive ventilation, but of interest and no surprise, I think, for patients who were in the ICU and patients who had a body mass index greater or equal than 30, the effect was even more pronounced. So especially when we have patients who might have some hypoventilation at baseline, obviously utilizing non-invasive as our pre-intubation oxygenation is important. Now, it might have practical aspects. If you have to intubate somebody emergently, are you going to bring in the non-invasive and try to set that up? On the other hand, I think if you have somebody who's having difficulty breathing in the ED, or you're trying to figure out what to do, I mean, while you figure out, maybe slapping on a non-invasive is a good way to get started and get ready for the intubation procedure itself. So clearly, I think this is a valuable study, and it should influence what we do at the bedside. The second study, inhaled amikacin to prevent ventilator-associated pneumonia. I'm not going to go into detail here. This was the amikacin HAL trial published in the New England Journal of Medicine. This was a multi-center prospective randomized double-blind trial in 19 French ICUs, a little bit under 1,000 patients, 850 patients with adults on mechanical ventilation for 72 hours or more were randomized to inhaled amikacin at a dose of 20 milligrams per kg every day times 3 doses versus placebo, similar dosing, similar duration. Their primary outcome was first episode of VAP during the 28-day follow-up. Secondary outcomes included the incidence density of VAP, so that is VAPs per 1,000 patient days of invasive mechanical ventilation, incidence of VAP with gram-negative susceptible to amikacin, and other ventilator-associated conditions, plus they looked at ICU mortality and hospital mortality. So in terms of the outcomes, the incidence of the first VAP episode, the difference was significant. It was about 1.5 days in favor of using the inhaled placebo. So the incidence of the first VAP and inhaled placebo occurred later. They looked also at ventilator-associated complications were significantly lower in the inhaled amikacin. So the difference in the VAP episodes was 22% in the inhaled placebo versus 15% in the inhaled amikacin, and that was associated also with a lower infection-related ventilator-associated complications. So when they didn't meet the criteria for VAP, in terms of adverse side effects, they were very similar, 2% and 1% in both groups, so no significant difference. So this was considered a positive study. I think that in many ICUs, VAP might still be a problem. So in those cases, I mean, maybe considering the use of inhaled amikacin might be of value. I think there was also similar studies in TBI patients, but with systemic antibiotics. Obviously, using prophylactic antibiotics always raises the question of generating more resistance. That was not seen with this inhaled dose of amikacin for 3 days, which obviously relates to less systemic absorption, but also was effective in preventing VAPs. The third article relates to stress ulcer prophylaxis during invasive mechanical ventilation, something that we've done for years, and I think almost like dogma for many years. However, when people have looked at the evidence, and I think that's why it's important to find reproducible evidence, to look at the evidence over and over again, and when these studies can be done, I think we should be paying attention. This was done by the Canadian Clinical Trials Group. It was an international prospective randomized double-blind trial with 68 hospitals, almost 5,000 adults on mechanical ventilation. And the reason for this is that a lot of people have questioned whether pantoprazole really has an impact on decreasing GI bleedings. There's concerns of increase with C. diff or VAP and maybe other complications. So they compared pantoprazole 40 milligrams IV Q-day while the patient was intubated to placebo at a similar dose while the patient was intubated. And the primary outcome was clinically important upper GI bleeding up to 90 days post-randomization. Clinically important is defined objectively and relates to the need for transfusion or other interventions. A primary safety outcome was death from any cause at day 90. And they looked at secondary outcomes such as C. difficile infection, C. diff, VAP, initiation of RRT, ICU and hospital mortality, and patient-important GI bleeds. The primary safety outcome was significantly lower, 1% versus 3.5%, with an absolute difference of 2.5 or 1.6 to 3.3 in a 95% confidence interval. So that was statistically significant. And the primary safety outcome was very similar at 29.1% for the 90-day mortality versus 30.9%. They looked at other secondary and tertiary outcomes. And again, in terms of the incidence of C. diff infection or the incidence of VAP, no significant difference between pantoprazole and placebo. Other tertiary outcomes in terms of number of red cells transfused was similar. Medium peak serum creatinine, no difference. Median number of days on mechanical ventilation, no difference. Median number of days in the ICU was no different. So again, I think that what this study demonstrated was that pantoprazole was better at preventing clinically significant GI bleeds, but did not have an impact on mortality. Yet I think it still informs our use of GI prophylaxis for patients on mechanical ventilation. This was a very well conducted, large study, which I think supports the use of pantoprazole to prevent clinically significant GI bleeds. It's not going to improve mortality. It's not going to cause C. diff. It's not going to cause an increased risk of VAP, but it might prevent patients from having significant GI bleeds, which I think is a positive outcome, and most patients probably would consider to be important. The following study is a study that I just found interesting. I think very well conducted on a topic that I think is dear to all of us since our internship days, which is potassium supplementation and prevention of atrial fibrillation after cardiac surgery. This was the TITE-K randomized clinical trial published in JAMA. And I think that one of the most frequent interventions in the hospital, especially when we were in our training days, was to replace potassium. Today, obviously, many ICUs have protocols for this. And it's interesting that when we revise these protocols, the cardiac ICU and the cardiac surgery ICU teams are always very concerned about at what point should we transfuse potassium. And I think it's been kind of handed down to us as dogma that we should keep the potassiums 4.5 or above for these cardiac patients to prevent arrhythmias. So this was a prospective randomized multi-center open label non-inferiority trial in 23 cardiac surgical centers in the UK and Germany. Their hypothesis was that we don't have to keep potassium above 4.5, that all we have to do is keep it normal in order to prevent atrial fibrillation. And as I said, this was designed as a non-inferiority trial, so they randomized almost 1,700 post-isolated CABGs to either a TITE-K group, in which potassium was replaced whenever it was below 4.5, and a RELAX-K group, in which potassium was replaced when it was below 3.6. The primary outcome was confirmed new onset AFib, so AFib after cardiac surgery in first 120 hours post-CABG or by discharge. And in order for this to be confirmed, it had to be clinical, documented in the EKG, and also every patient had an ambulatory heart rate monitor, and the three of them had to show AFib. Secondary outcomes included new onset atrial fibrillation after cardiac arrest detected only on the on the ambulatory heart rate monitor, or non-atrial fibrillation episodes detected on the heart rate monitor. They also looked at cost and they looked at safety outcomes. So in terms of the primary outcome, there was no difference. There was 1.7% difference in the unadjusted, and that was 2.2 in the adjusted. Both of these crossed a line of non-significance in the 95% confidence interval. So bottom line is that the incidence of atrial fibrillation after cardiac surgery seemed to be the same, whether the potassium was kept above 4.5 or was kept just normal above 3.6. They looked at secondary outcomes. Again, there was no significant difference between these. So this being a non-inferiority trial, and the hypothesis that just keeping potassium normal above 3.6 was no different than going into keeping it above 4.5, I consider this a positive trial. They obviously showed that the frequency of potassium administration was significantly higher in the TITE-K group, and that the potassiums were separated in both groups, but in general, in both groups remained normal throughout the first 24-hour period post-surgery. So an interesting study that I think provides some evidence to a practice that is extremely common, that I think is hard to study, obviously. I mean, people are not interested in just potassium replacements. But why is this important? Well, I think that a lot of patients will tell you getting potassium is not always fun. It can cause pain. It's not necessarily comfortable. But also, even though potassium is not an expensive drug, the sheer amount that is utilized is an important cost. And in an era when we're trying to provide value to patients, but also to healthcare in general, I think to continue to do practices that are based on dogma and not current evidence don't make a sense if they don't improve outcomes and they just increase cost. So some food for thought. I hope you discuss this with your cardiology and CT surgery colleagues. And I thought I bring it to your attention. The next study, which I believe is the last clinical trial that I really wanted to focus on, is a recent published antibiotic treatment for 7 versus 14 days in patients with bloodstream infections. This is the BALANCE trial, published in the New England Journal of Medicine. This was a multi-center prospective randomized non-inferiority trial, 74 hospitals in 7 countries. It included 3,600 adults with a bloodstream infection, and they basically got randomized to either 7 days of antibiotic versus 14 days. Very important in this particular trial is to recognize exclusion criteria. So they excluded patients who were immunosuppressed, and they have a definition for that. They excluded Staph aureus infection, which I think is very important for us in the ICU. They also excluded specific infections that required extended treatment, especially when they're foreign bodies or certain locations. And they didn't include possible contaminants in the study. So the primary outcome was death by any cause at day 90 post diagnosis of the bloodstream infection. Secondary outcomes included death in the hospital, death in the ICU, relapse of bacteremia with the same pathogen, allergy to antibiotic, adverse events, C. diff colitis, and secondary infections with multi-drug resistant organisms. The patient characteristics were very similar. The median age was 70 years old. The median SOFA score was 4. The percent of patients enrolled in the study that were in an ICU was 55%, so the majority of patients were in the ICU. But in order to get to 3,000 plus patients, they also enrolled patients who were in the hospital ward. So these were all inpatients. 21% of these patients received mechanical ventilation. And in terms of the sources of the acquisition of bacteremia, the vast majority, 75.4%, were from the community. Around 13 to 12% were from the hospital, acquired in the hospital, and 11% were acquired in the ICU. When you look at the primary outcome, they looked at intention to treat per protocol, and then they had a modified intention to treat. And then all 3 of these, there was no difference between 7 days or 14 days in the primary outcome. And really just illustrates that for non-Staph aureus and for maybe not endocarditis or an infected joint or a foreign body, for many of our documented clinical infections with bacteremia, 7 days is as good as 14 days. And I think it just speaks to the fact that for whatever reason, antibiotics seem to be given in multiples of 7. That's a week. I presume we're very arbitrary. I think when we really think about infection, we recognize that 2 patients with the same bug might require different durations of antibiotic therapy. Some people have looked at procalcitonin and other biomarkers to dictate that, but I think that in general terms, this will cut down on the exposure to antibiotics intravenously. I think it has important implications for patients from a disposition perspective, from a cost perspective for healthcare, and especially in these infections that were studied here, there's no significant difference. I think that aiming for 7 days as a baseline probably is the way to go. So those were the 5 main studies that I felt were quite relevant to our practices. Like I mentioned, there are many other studies that were very, very, very well conducted that have important implications, but these somehow hit the spot of really being relevant to our daily practices, being well-conducted studies, being large studies, and having some degree of a positive finding that ultimately I think can inform our practice. I have one bonus study that I felt to be really interesting and made me think a lot about my patients. And this study was also published in the New England Journal of Medicine, and it relates to cognitive motor dissociation. So, what do we mean by cognitive motor dissociation? Is when we have basically a exam that seems to be a comatose patient not responding to anything we do to them, yet we find when we study them deeper, either with a functional MRI or a special EEG, that perhaps there are responses to some of our commands, and there are responses to some of our actions. And the idea here is that our exam might be very superficial and not fine-tuned enough or sensitive enough to really understand the level of consciousness of a patient. Now, obviously, when we're dealing with traumatic brain injury, post-cardiac arrest, understanding the level of consciousness and where this patient's brain is extremely important in terms of making therapeutic decisions. I just found that this was a very interesting study, despite being a little bit smaller, but also one that I'm sure is very difficult to conduct. So what they did here is they evaluated a whole bunch of patients, many of which were in the ICU, who had different disorders of consciousness post-critical illness. And basically, they eventually found a group of 350 patients who actually had either a Coma Recovery Scale completed, which is a large physical exam scale that looks at different points for and gives a total score for the coma. They had a functional MRI, and they had a complete EEG. So either both the functional MRI and the EEG, or one or the other. So they really looked at 350 patients that had all this testing done. They were able to move them into two different groups. One group, so 32% of these patients, 30% of these patients had observable response to commands. And that obviously was not necessarily the group of interest. That would be like the control group. And then there were 241 or almost 70% of the patients did not have observable response to commands. So these are the patients that we would say no response to commands, are not following when I examine them. They're comatose, they're unresponsive. Of these, 25%, so 1 out of 4, had responses to commands on imaging and were considered to have cognitive motor dissociation. So when we looked at them in more depth, they were responding appropriately to our commands, either in the functional MRI or in the EEG. So really, when you look at the characteristics of the patients who did not have an observable response to command, the majority of them were either in coma or vegetative state. Some had what they call minimally conscious state. The majority of them were male, 65%. And the 45% were from brain trauma, 20% were from cardiac arrest or hypoxia, another 20% were from some sort of cerebrovascular event, either a subarachnoid hemorrhage, intraventricular hemorrhage, intracranial hemorrhage, or a stroke, and the rest were just miscellaneous. I think that a summary of these findings is that of those, 70% of patients have no observable response post critical illness affecting the brain. Of these, in this group, and of that, almost 1 out of 4 had actually cognitive motor dissociation. So there was more response that we were able to ascertain by our physical exam. And this is much more common in younger patients below 30, which obviously are the majority of patients who have traumatic brain injury, and decreases in the different age groups. So it was lower in 30 to 50, and then lower in over 50 years old. But this is a powerful study because it just reminds you of how little we know about the brain, and how sometimes we just maybe write off somebody as being unresponsive, yet we don't really know what their level of consciousness is. Not to mention that we could miss the lock-in syndrome. That is a little bit more rare. This is just people who our exam is not picking up responses that are picked up by more sensitive testing, such as functional MRI and EEG. Now, don't get me wrong, the majority of these patients probably still have a pretty poor prognosis, But I do think that as we evolve, understanding the extent of brain injury, understanding um, the real level of consciousness, the real ability to respond is something that needs to evolve. And it's something that should um, provide a lot of pause when we examine somebody, not to just assume that there's nothing there because we might be missing something. So I just found that this sixth article as a bonus was a good food for thought type of article just to give us a little bit more humility when we're rounding and examining patients. So with that, we covered two important clinical guidelines, 5 clinical trials, and this extra bonus study. I will add references in the show notes. I hope you pick up some of these and read them. Highly encourage you to look at the clinical guidelines. A lot of information there that I think informs how we should be organizing protocols for these patients post cardiac arrest. Also look at these studies. Every single one of these studies I think impacts something that is very common in our ICU. I would almost say something that's daily in our ICUs. And that's one of the reasons why I chose them. And to finish, as we always do now, I'll give you some thoughts or some answers on questions that are unrelated to the clinical topics that we discussed. And always start with books. So I will share with you 3 books that really marked me this year that I found to be extremely valuable. And I'll give you a little bit of what I learned from them and hope that you pick up one of these and read them. I think they'd be great. Any one of these would be, I think, a great read. So the first book is Slow Productivity, The Lost Art of Accomplishment Without Burnout. This is a New York Times bestseller by Cal Newport. I think Cal Newport is a great ideas writer. He's a professor at Georgetown and computer science, but really focuses on the interface of technology with work and how to be productive. 3 things that I really learned from Slow Productivity is that if you do fewer things, you're going to be much more productive, which I think in a world where there's so many distractions is an important reminder. Number 2, that we should work at a natural pace, not always be rushed, and really be present in whatever task we are doing at this moment. And I think that's the way to achieve more, but also to achieve better things. And finally, I think he talks a lot about obsessing over quality. And this in particular, I think, is important. Whenever we do something, no matter what it is, we should really be present and try to do it the best we can. That is really, I think, where flow comes from, where joy comes from. And I think it's perhaps the biggest antidote to burnout in the workplace. The second book is called Meditations for Mortals, 4 weeks to embrace your limitations and make time for what counts. This is from Oliver Burkeman, who also wrote 4,000 Weeks, a phenomenal book. For Meditations for Mortals, I think it's the perfect book to read as the year starts. The intention is for you to read 1 chapter every day for 4 weeks. And really, I think he focuses on the idea of embracing imperfection. We can't do everything we have to do. So we should just embrace that and pick the things that are important. Focus on what matters. And what matters is uniquely individual for each one of us. So taking the time to really identify what is important for us in the ICU, at the bedside, what's important for us at home, what's important for us in our work, and making sure that we create time and effort for that, I think is very, very important. And finally, it's really about letting go of control. We think we have control over things we don't. And I think that if we instead focus on the things we do control, which is how present are we, what are we choosing to spend our time on, who are we choosing our time to spend our time with, I think that we will have a much more meaningful life. So these two actually, I think, have some overlap, although they focus on different things. One is very specific to work, and the other one is more specific to life. Highly recommend it. And then finally, the last book, which I recently finished, is called Knife: Meditations After an Attempted Murder, and it's from Salman Rushdie, which many of you might know as a very prolific fiction author, who many years ago wrote a book called The Satanic Verses and had a fatwa, or a order to to kill him place. That was 30 years ago. And a couple of years ago, actually, somebody went through with that and stabbed him at an event, I think 15 times. And he writes about his ordeal of surviving that. And he writes about his recovery from that trauma. And really, what was very interesting from this book is it forces you to really understand the importance of confronting our personal demons. We all have demons, and grappling with them, accepting them, and understanding them, I think, is quite important. I also appreciated the complexity of identity from this book. I don't know much about Salman Rushdie. I haven't read many of his books. Obviously, I think a lot of people made opinions about him based on his history. But the truth is, when you read this very personal and vulnerable account, you see that, like any person, he has many, many facets, very complex, like every one of us. And I think that's an important point for empathy, right? Empathy and compassion towards others. We never know what people are going through, and I think we should always think about that. And finally, I think it's a great, great testament to the power of storytelling. And just, how we learn from stories, and how, whether it's fiction or nonfiction, our ability to tell a story is ultimately what allows us to communicate ideas. So those are 3 books that I highly recommend from 2024. Pick up one of those. I'm sure that you will enjoy them. The second question that I usually ask my guest is, what is something that you have changed your mind about? And I think especially in a election year, one of the things that I've changed my mind about is my tendency to be judgmental about others who think differently about me, and recognize that people feel differently politically, religiously, spiritually, even scientifically, for a platitude of reasons. And that instead of me trying to explain my position and trying to convince others, which I think is really a lost battle, I should ask more questions. I should try to learn. I think that is much more valuable. And it's something that I really changed my mind about over the last couple of years. And I've tried to implement on a regular basis, where it's discussing science, discussing sports, discussing politics, discussing the spiritual, is to be more curious and not try to tell people what I think, but try to learn from them, or try to see why are they thinking what they're thinking, even if I don't agree. And that leaves me with my closing statement, which I think is tied to this, and is also very important when conflict arises, whether it be at home or at work. And it's something I read that is very powerful. And basically it states that you can't be furious and curious at the same time. Choose to be curious. So I hope you have a curious 2025, that you ask a lot of questions, that you always seek to learn, and look forward to talking with you again soon on the podcast and meeting you in person and talking about obviously critical care topics, but also topics just related to life. So happy New Year, and see you in 2025.
Thank you for listening to Critical Matters, a sound podcast. Make sure to subscribe to Critical Matters on Apple or Google Podcasts and share with your network. Sound's transforming the way critical care is provided in hospitals across the country. To learn more, visit www.soundphysicians.com.